Somatic symptom disorders may seek the sick role because it provides relief from stressful interpersonal expectations and, in most societies, offers attention and caring. Somatic symptom disorders are characterized by multiple and often vague physical symptoms that are distressing and interfere with daily functioning. There are excessive thoughts, feelings, and behaviors related to the somatic symptoms. Typically, the symptoms are recurrent. Complaints may occur over a few months, involve any body symptom, and often persist for years. They may begin or get worse after a job loss, death of a loved one, or another big type of loss. Stress tends to intensify the symptoms as well. Patients with somatic symptom disorder may have impairments in occupational, social, and other functioning and may become extremely dependent in their relationships. For some people, somatization progresses to a form of chronic illness behavior. In the most extreme cases of somatization, the sick role becomes the person's predominant mode of relating to the world. Patients may seek care from multiple physicians, which can lead to confusion in treatment and conflicting treatment plans. Even when presented with medical evidence to the contrary, patients with somatic symptom disorder will think that the worst about any of their health problems, assuming a high degree of medical seriousness associated with their presenting symptoms. Unfortunately, these individuals often undergo unnecessary surgeries, invasive diagnostic procedures, and drug trials, all of which can be life-threatening. The cause of somatoform disorder is not known for sure, but it's thought that people who have a history of abuse are more likely to suffer from the disorder. These disorders are grouped together because the symptoms suggest a physical disorder, but after thorough physical exams and laboratory tests are completed, no clear organic cause or physiological mechanisms can be identified. Somatic symptom disorder is one of the most difficult disorders to manage because the symptoms tend to change. They're diffuse and complex, moving from one body system to the next. The individual isn't likely to acknowledge any psychological aspect of the symptoms or consider psychiatric treatment. Cognitive behavioral therapy seems to be beneficial for lowering anxiety levels, regulating activities, increasing emotional awareness, and providing cognitive restructuring and interpersonal communication skills. However, these disorders are usually chronic and relapsing, characterized by excessive or maladaptive responses to symptoms, and rarely remit completely. Often the following types of things occur in people with somatic disorders. One of them being disproportionate and persistent concerns about the medical seriousness of one's symptoms, high levels of health-related anxiety, and excessive time and energy devoted to the symptoms or health concerns. These people often have a hard time getting anything else done in their daily lives because they are concerned about the unexplainable symptoms that they're having. Pharmacological treatment depends on the patient and the physician. If a coexisting depressive or anxiety disorder are present, perhaps an SSRI may be needed to help cope, but the use of anti-anxiety medications or pain medications are not wise due to the risk of abuse or dependency.
In today's session, we're going to talk about somatic symptom disorder. Somatic symptom and related disorders are characterized by prominent somatic symptoms associated with distress and impairment, and are more often encountered in primary care and other medical settings than in psychiatric or other mental health settings. A characteristic distinctive of all somatic symptom and related disorders is that the diagnosis is often less about physical complaints and more about the way that they are presented or interpreted. Affective, cognitive, and behavioral components are incorporated into the criteria for somatic symptom disorders, providing a more comprehensive and truer reflection of the clinical picture. This group of disorders overlaps significantly with mental disorders formerly diagnosed under the umbrella of somatoform disorders. But the conceptualization, descriptions, and diagnostic categories are quite a bit different from those. The diagnosis of somatic symptom disorder is characterized by one or more somatic symptoms that are distressing or result in significant disruption of daily life. coupled with excessive thoughts, feelings, or behaviors related to the symptoms or health concerns. Even if any one somatic symptom is not present on a continuous basis, the state of being symptomatic is persistent, typically lasting for more than 6 months. The DSM-5 offers specifiers of with predominant pain for individuals whose somatic symptoms predominantly involve pain, and persistent when there are severe symptoms, marked impairment, and a long duration of more than 6 months. Excessive thoughts, feelings, or behaviors, and health concerns present in the disorder can be manifest by A. disproportionate and persistent thoughts about the seriousness of one's symptoms, and/or B. persistently high level of anxiety about health or symptoms, and/or C. excessive time and energy devoted to these symptoms and health concerns. Specifiers for current severity are mild, if only one of the manifestations of excessive concern are present, moderate when 2 or more manifestations of excessive concern are fulfilled, or severe if 2 or more manifestations of excessive concern are fulfilled, in addition to multiple somatic complaints or the presence of one very severe somatic symptom. Risk factors for developing somatic symptom disorder include personality traits of negative affectivity and environmental factors such as a few years of formal education, low socioeconomic status, or recent experience of a stressful event. Prevalence is really unknown, but estimated to be around 5 to 7% of the general adult population, with females tending to report more somatic symptoms than do males. The development of the disorder is associated clearly with marked impairment in one's health status. Let's practice with a question for somatic symptom disorder. Stacy, age 42, claims that for 10 months she has lower back pain, gastrointestinal troubles, and a slight discomfort in her forehead. She has been to 3 different physicians, and although she continually says these symptoms exist, the physician claims otherwise. Her symptoms more than likely point to A. acute anxiety disorder, B. somatic symptom disorder, C. generalized anxiety disorder, and D. functional neurological symptom disorder. The correct answer is B. Acute stress disorder is an anxiety disorder that can develop in individuals who have been exposed to a traumatic event in which there is a threat or experience of death, serious injury, or risk to one's physical integrity, or to the individual and/or others, which makes answer A incorrect. Individuals diagnosed with a generalized anxiety disorder demonstrate excessive worry and anxiety surrounding a variety of topics, for example, work, school, or one's health, for at least 6 months, making answer C false. Conversion disorder, also known as functional neurological symptom disorder, occurs when an individual develops symptoms affecting voluntary motor or sensory functions. Although the impairments in functioning are suggestive of a neurological condition, they are etiologically related to psychological rather than medical factors, making answer D false.
Concerning genetics and familial factors, there is no direct evidence of a genetic etiology for any one specific somatic symptom disorder. However, some physiological data support a genetic theory that somatization disorder tends to occur in families presenting in 10 to 20% of first-degree female relatives of women with somatization disorder. Twin studies show an increased risk of conversion disorder in monozygotic twin pairs. First-degree biological relatives of people with somatic symptom disorder associated with chronic pain are more likely to have chronic pain, depressive disorder, and alcohol dependence. Some believe that genetic and familial factors could play a significant role in the predisposition to somatic symptom disorders. These disorders are associated with characteristics such as low pain threshold, poor ability to express emotions, also known as the alexithymia, and patterns of information processing characterized by distractibility, impulsiveness, and failure to habituate to repetitive stimuli. When discussing genetic and environmental origins, twins have been researched quite a bit. Twin studies have repeatedly supported the findings that somatic symptom disorder is moderately heritable. The study included monozygotic twins as well as dizygotic twin groups. They evaluated for health anxiety, which ranges from mild to severe, with severe meeting the criteria for hypochondriasis. There are several facets of health anxiety that include health-related fears, disease conviction, excessive health-related behaviors, and impairment in occupational functioning. Learning and sociocultural factors play a major role in the theory of how one develops somatic tendencies. Research supports the idea that early experiences and learning are the primary factors of somatic sensitivity and bodily preoccupations. One hypothesis is that an adult presenting with somatic symptom disorder may display attentiveness to the same symptoms that were a source of parental attention during the person's childhood. Constant attention to a specific body part enhances the ability of a person to direct sensations to that body part. Therefore, symptoms are reinforced by constant parental attention, and the child learns the benefits of the sick role. Psychological theory is that if the parents are unavailable, harsh, or inconsistent, and fail to acknowledge the needs of the child during the separation and individuation phases, a process of self-focus develops. The child, and later adult, learns to focus on the body as a defense against stress and mental pain because the emotional and nurturing needs as a child were not met from the outside world. In regards to the interpersonal model, there is growing evidence that childhood adversity is linked to adult somatic symptom disorder. Many patients report traumatic events and substance abuse in their families compared with other families. Yates identified some childhood influences that are thought to contribute to somatization. One of them being children raised in homes that there was a high degree of parental somatization may model that somatization in the child. Another is that early sexual abuse may be associated with increased risk of somatization later in life. Childhood physical abuse and sexual abuse are also associated with conversion disorder, dissociative disorder, and many other disorders. Cultural factors can influence an individual's tendency to develop somatic symptoms, as well as the types of symptoms that unconsciously might be used. In some cultures, somatic symptoms may be the first symptoms that indicate a patient may have an underlying anxiety or depressive disorder. An international study reported frequent somatic presentations in primary care worldwide. The study showed that Latin American patients reported the highest number of somatization symptoms. In a primary care study of multi-ethnic sample in the United States, it was found that Central American immigrants had significantly higher rates of somatization than other ethnic groups, and that the war exposure was the single most significant predictor of medically unexplained somatic symptoms in these patients. Interestingly, in that same study, they also found that recent immigrants had lower rates of PTSD than U.S.-born patients, despite the immigrant patients' higher trauma exposure. This resilience has been well documented for Mexican Americans and extends to several other health and other mental health dimensions as well. Cross-cultural studies of depressed patients have documented higher levels of somatic complaints among depressed psychiatric patients in Asia and Latin America. This is compared to depressed patients in the U.S. Factitious disorder imposed on another, or factitious disorder by proxy, has the same criteria as a factitious disorder, except in this case the deliberate fabrication of symptoms or injury are imposed upon another person, often a child. Munchausen syndrome is the most severe and chronic form of factitious disorder and can result in self-harm severe enough to require hospitalization. Doctor shopping is an attempt to seek surgery and invasive diagnostic tests, often seen in patients with Munchausen syndrome. A caregiver manifests this syndrome imposed on another. This is usually a mother with a healthcare background. The parent is often found to be injuring a child to receive attention or sympathy. You also see this kind of elaborate thinking with histrionic patients as well. Warning signs to look for when you believe that someone presents with factitious disorder are like dramatic but inconsistent medical history, unclear symptoms that are not controllable, become more severe, or change once treatment has begun, predictable relapses following improvement in the condition, extensive knowledge of hospitals or medical terminology, as well as textbook descriptions of the illness, presence of many surgical scars, appearance of new or additional symptoms following negative test results, presence of symptoms only when the patient is alone or not being observed, willingness or eagerness to have medical tests, operations, or other procedures, history of seeking treatment at many hospitals, clinics, or doctor's offices, possibly even in different cities. And lastly, reluctance by the patient to allow healthcare professionals to meet with or talk to family members, friends, or prior healthcare providers, in fear that they'll realize that the patient is lying about these different symptoms that they have.
Well, tonight we are continuing our coverage of the Angola woman accused of faking cancer to get money from a fundraiser. Last night, in a News Channel 15 exclusive, April Landis said she has factitious disorder and that it made her think she had cancer. Today, News Channel 15's Alyssa Ivinson talked with one of Landis's relatives, and what did she have to say?
Well, she says April Landis has a history of making up illnesses, and she thinks April is lying again now. But Landis says she's never tried to scam anyone. So you absolutely did not lie to get money from a benefit?
No, ma'am. Nope. Like I said, I'm not about money.
In an exclusive News Channel 15 interview, April Landis says she has a mental condition called factitious disorder. Landis faces 4 felony fraud charges. Police say she faked having cancer to get money from a fundraiser. But Landis says the factitious disorder made her believe she really was sick.
A factitious disorder is the development of psychological or physical symptoms. They're starving for attention, they're starving for sympathy. And there is really no better way than having a medical problem.
Dr. Stephen Ross is a clinical and forensic psychologist. He says people with factitious disorder will often go to doctors over and over with different symptoms, even create physical symptoms. But the key is it's just for attention.
A true factitious disorder, they believe that they have a real problem. Now, the point to be made is this. If there is a secondary benefit, a gain of some sort, money, getting off of responsibility for a criminal offense, that puts it into a different category, that puts it into a malingering.
Landis says she's always had migraines, fainting spells, and other issues growing up.
Stomach aches, whatever, and a lot of that actually, from what they're thinking, was, you know, all brain.
Today, News Channel 15 also talked to one of Landis's relatives. She didn't want us to use her name, but says Landis has a history of saying she's sick, even saying her kids are seriously ill. She says after a family member had a heart attack, Landis said she had heart problems the next week. Landis said she had cancer a week after her grandmother died from the disease. Now, this family member isn't buying the factitious disorder.
I don't understand it, how everything could be so real to me, but not to everybody else.
Landis showed us paperwork from the Northeastern Center in Auburn diagnosing her with the condition, and she says she still struggles. Part of you still thinks and believes that you have brain cancer.
Yes.
Right now.
Yes.
At this very moment.
Mm-hmm.
Landis is going to therapy once a week. She'll be in court for the felony charges on May 14th. Live in News Control, Alyssa Ivinson, News Channel 15.
The most frequent symptoms are pain, usually head, chest, back, joints, and pelvis, dysphagia, nausea, bloating, constipation, palpitations, dizziness, and shortness of breath. Although vague symptoms such as fatigue may also be prominent, sexual symptoms such as lack of libido or erectile dysfunction, or that pseudo-neurological symptoms such as fainting or color blindness may also be present. Usually the disorder appears before the age of 30. One or more of the somatic symptoms are distressing or cause a significant functional impairment. When describing their symptoms, individuals may describe them in very exaggerated and colorful ways, or have symptoms that do not generally co-occur with a serious disease. Individuals with somatization disorders often have histories of repeated surgeries, alcohol or drug abuse, marital instability, and suicide attempts. Because somatic disorder often co-occurs with a mood or anxiety disorder, when diagnosed, these co-occurring symptoms may be treated, or should be treated, really. Physical symptoms that are caused by anxiety or depressive disorder often resolve dramatically with treatment. Unfortunately, these individuals refuse referral to a psychiatrist because they believe that their symptoms are physical. Even though negative test findings persist, people with somatic symptom disorder experience severe distress, and their ability to function in personal, social, and occupational roles is often impaired. What used to be known as pain disorder is now specified under somatic symptom disorder. Prominent pain is one of the most frequent reasons people seek medical attention. When testing rules out any identifiable natural cause for the pain and discomfort leads to a significant impairment, a specifier of predominant pain would most likely note somatic symptom disorder with pain. Although most pain can be alleviated, chronic pain results in significant disability and high health care costs. People with somatic symptom disorder with a specifier of predominant pain often have a very low quality of life because they can be severely disabled by their symptoms. They may live like invalids, working infrequently, not attending school, and avoiding social obligations. Pain is often associated with a stressful life event and is potentiated by secondary gains, this being attention, freedom from responsibilities, or from conflict-producing situations, and often has financial rewards. When these secondary gains are reinforced, the symptoms often are also reinforced, making it more difficult for the person to relinquish the symptoms. Chronic pain, real or imagined, is extremely disorganizing and distracting and can make life very difficult. Suicide can be a serious risk for these patients as well. Pain is difficult to measure objectively, and individuals react differently to the same sources of pain. Frequent comorbid conditions include depression, substance dependence, and personality disorders. These patients are at risk for excessive use of narcotic or sedative medications. Some research suggests that a background of sexual abuse or poor social skills or even trauma is common in people with somatic symptom disorder with chronic pain. The course for somatic symptom disorder with a pain specifier varies according to the acuity of the symptoms. Acute pain with somatic symptom disorder has a favorable prognosis, but chronic pain is more difficult to treat. Antidepressants tend to decrease pain intensity for some of these types of patients. Conversion disorder is marked by the loss of or change in voluntary, motor, or sensory functioning. For instance, blindness or paralysis that suggests a physical illness but has no demonstrable physiologic basis. The symptom likely has a psychological basis, although it may not be readily identifiable. Conversion disorders are among the most common of the somatic symptom disorders and has been found to affect 2 to 3 times more women than men. The symptoms are not under voluntary control. Unlike factitious disorders, the patient with conversion disorder doesn't intentionally produce the symptoms, although they may have the unconscious motives of primary or secondary gain. Oddly, many individuals with conversion disorder don't show concern over the symptom or their functional limitations. French for the beautiful indifference, la belle indifference, is an apathy that associated with conversion disorder, but should not be used as an isolate indicator of this disorder. Lastly, socioeconomic factors that seem to be related to conversion disorders include lower education and income levels and residence in rural areas. Some studies have found an association between childhood physical or sexual abuse and conversion disorder. Body dysmorphic disorder, or BDD, is a highly distressing and impairing disorder. Body dysmorphic disorder occurs when a patient dislikes their physical appearance, usually their face, head, or skin. Any slight defect causes distress to a point where the patient is unable to perform activities of daily living. Flaws can be scars or shape and size of the body structure. Compliments by others are not reassuring. The cause of BDD is unknown. Some researchers report a genetic predisposition to psychiatric disorders that lead to developing BDD. Other researchers believe an imbalance of serotonin may be the underlying cause of it. Still, other researchers believe that cultural influences that define an ideal physical appearance lead to patients with low self-esteem to define their self-worth by their ideal physical appearance. A patient diagnosed with BDD may become isolated and avoid intimate relationships. The patient focuses attention on fixing their appearance. A patient is at risk for suicide ideation and suicide attempts if the patient is not treated. Cognitive therapy is the first line of treatment for this kind of patient. The focus is to help the patient to identify triggers and alternative behaviors to engage in when the patient encounters a trigger. The pharmacological agents of choice for people with BDD are selective serotonin reuptake inhibitors. SSRIs and tricyclic antidepressants, again, are the major lines of treatment. One person that you may know that is said to have had BDD was Michael Jackson, and that was why he was so obsessed with changing his nose and the color of his skin. But again, that is not completely known. Because patients with somatoform disorders are seldom admitted to psychiatric units, specifically because of their disorders, long-term intervention usually take place on an outpatient basis or in the home. Short-term planning may be initiated if the patient is admitted to a medical surgical unit. Such a stay is usually short, and discharge will occur as soon as the diagnostic tests are completed and negative results are received. Nursing or clinician interventions should focus initially on establishing a helping relationship with the patient. The therapeutic relationship is vital to the success of the care plan, given the patient's resistance to the concept that no physical cause for the symptoms exists and the patient's tendencies to change caregivers. To be successful, therapeutic interventions must address the ways to help the patient meet needs without resorting to somatization. The secondary gains the patient has derived from illness behaviors become less important to the patient when underlying needs can be met directly. The optimal goal is not only to relieve symptoms, which the patient does believe are real, but also, and more importantly, to increase quality of life and independence. Collaboration with family or significant others is essential for their success. Remember, when patients complain of physical symptoms, take the symptoms seriously, because even if a medical explanation is not found, the symptoms are real and troublesome to that patient. If you look at the table 12.2 in your book, it lists several interventions that are appropriate when caring for a patient with a somatoform disorder. Cognitive and behavioral approaches can be effective and may prove to be the therapy of choice for patients with somatic symptom disorders. Behavior modification can provide incentives, motivation, and rewards to help patients control their symptoms. Family and group therapy can increase awareness of communication and interaction patterns and to help patients improve interpersonal communication and learn strategies to improve social skills. Nurses and other clinicians may be involved with teaching patients alternative coping skills, such as relaxation techniques, cognitive restructuring, and refocusing. This is all to aid in controlling anxiety and reappraising thinking in an effort to better mediate symptoms. Refer to Table 12.3 for a summary of characteristics of somatic symptom disorders, their comorbidities, and specific therapeutic approaches that have the potential to improve the quality of life for these types of patients. Currently, antidepressants, specifically SSRIs, show the greatest promise for helping patients suffering from somatic symptom disorders. Patients may also benefit from short-term use of anti-anxiety medications, but they must be monitored carefully for the risk of dependence. The nurse may administer these medications in certain settings, but teaching about the medications to patients and families is helpful in all settings. Dissociative disorders are psychiatric disorders where the patient feels detached from themselves and reality. Feeling detached from oneself is called depersonalization. Detachment from the external world is called derealization. Historically, somatoform and dissociative disorders were classified as hysterical neuroses, which is why both are discussed in the same chapter. Neurotic disorders, according to psychoanalytic theory, stem from unconscious conflicts that increase anxiety, leading to symptoms of somatoform disorders and dissociative disorders as a defense mechanism to address conflicts. Dissociative amnesia occurs when the patient has acute memory loss related to stress, leading to the patient being unable to recall personal information. Researchers have found that many patients realize that they've experienced the amnesia. However, some patients are unaware of the amnesia episode, but know that some type of time frame has passed that they cannot account for. Dissociative fugue occurs when the patient leaves home to escape from a stressful situation, during which the patient temporarily assumes a new identity. During an episode of dissociative fugue, the patient is able to perform activities of daily living under the patient's new identity, which is more outgoing than the patient's normal behavior. The patient may experience amnesia during this episode as well. Depersonalization disorder occurs when the patient's self-awareness is temporarily altered, giving the patient the feeling of detachment from their own body or mental process. This disorder typically occurs after a life-threatening event. It can involve the entire body or part of the body. The patient remains in touch with reality, although the patient may feel that they are viewing themselves from the outside rather than from the inside. For people who use extreme dissociation as a defense against overwhelming anxiety, consciousness itself can be altered in a dramatic way, whereas thinking, feeling, and perceptions are less impaired. These disorders can be quite severe. We all dissociate. Fantasy, daydreaming, absorption in activities, and night dreaming are considered normal dissociation. For example, we say we are on autopilot when we drive home from work but cannot recall the last 15 minutes before reaching home. However, these common experiences are distinctly different from the processes of pathological dissociation, where the dissociation becomes distorted and interferes with the person's functioning and quality of life. People with these disorders routinely experience significant emotional pain and struggle with overall functioning and safety. Lastly is dissociative identity disorder. It occurs when a patient has two or more personalities, each of which can control the person's behavior, relationships, and memories. This used to be called multiple personality disorder. Research finds that the primary personality has a strong moral sense, and subsequent personalities have opposing personality traits, such as overly sexual or aggressive. The actual cause of dissociative disorders is unclear. However, as mentioned earlier, stress seems to play a major role. We have already mentioned that childhood physical, sexual, or emotional abuse and other traumatic life events are associated with adult dissociative symptoms. Several factors related to etiology are reviewed in the following sections. Current research suggests that the limbic system is involved in the development of dissociative disorders. Traumatic memories are processed in the limbic system, and the hippocampus stores this information. Animal studies show that the early, prolonged detachment from the caretaker negatively affects the development of the limbic system. For humans, early trauma or detachment from the caregiver could impair memory processing, leading to dissociation. Significant early trauma and lack of attachment have also been demonstrated to have effects on neurotransmitters, specifically on serotonin. One study found that people with dissociative identity disorder may have hippocampi that are about 19% smaller and amygdalae that are about 32% smaller as compared with the control subjects. The hippocampus is the part of the brain essential for memory and learning, and the amygdala regulates emotion. Extreme stress can cause alterations in the brain that may manifest as brain scan or abnormalities. Therefore, it would be prudent to examine dissociative disorders from both a brain and a mind perspective. Depersonalization disorder and dissociative fugue have a possible neurological link. Altered perceptions of self and fugue states occur that with neurological diseases such as brain tumors, epilepsy, and others, especially complex partial seizure disorder. Depersonalization is also experienced by individuals under the influence of certain drugs, such as alcohol, barbiturates, and hallucinogens. Several studies suggest that dissociative identity disorder is more common among first-degree biological relatives of individuals with the disorder than in the population at large. And there is also evidence that patient histories recount multiple generations of DID and occurrence among siblings. Learning theory suggests that dissociative disorders can be explained as learned methods for avoiding stress and anxiety. The pattern for avoidance occurs when an individual deals with an unpleasant event by consciously deciding not to think about it. The more anxiety-provoking the event, the greater the need not to think about it. The more this technique is used, the more likely it is to become automatically invoked as dissociation. When stress is intolerable, for example, in an abused child, the individual develops dissociation to defend against pain and the memory of the stressful event. Certain cultural bound disorders exist in which there is a high level of anxiety, a trance-like state, and running or fleeing, followed by exhaustion, sleep, and amnesia regarding the episode. These syndromes include Priblokto among native people of the Arctic, Navajo frenzy witchcraft, and Amok among Western Pacific natives. These syndromes, if observed in individuals native to the corresponding geographical areas, must be differentiated from dissociative disorders. With depersonalization, the person feels as if he or she is seeing themselves from a distance or outside of the body. Some patients even report the very disturbing perception of their limbs being larger or smaller than normal. In some cases, depersonalization may be preceded by severe stress. In other cases, there may be an association with childhood emotional trauma. With derealization, there is often an unreal, dreamlike distance or distorted experience in familiar surroundings. In both these instances of depersonalization and derealization, the symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning as specified in the DSM-5. The symptoms are not related to medication or substances of abuse or any other medical condition or mental disorder. Dissociative amnesia is marked by psychologically induced memory loss of an autobiographical nature and is marked by the inability to recall important personal information. Symptoms can cause marked distress, social, occupational, and other important areas of functioning. Localized amnesia, which is the inability to recall specific events during a specific time, and generalized amnesia, where the person experiences loss of memory of who they are and all autobiographical data, and often general knowledge about the world. It is reported estimations that between 5 and 20% of combat veterans were amnesic for the majority of their combat experience. Dissociative amnesia, with a specifier of fugue, is characterized by sudden, unexpected travel away from the customary locale and inability to recall one's identity and information about some or all of the past. In rare cases, an individual with dissociative fugue assumes a whole new identity. During a fugue state, individuals tend to lead rather simple lives, rarely calling attention to themselves, and after a few weeks to a few months, they may remember their former identities and become amnesic of the time spent in the fugue state. But usually, a dissociative fugue is precipitated by a traumatic event. Formerly called multiple personality disorder, DID, or dissociative identity disorder, is marked by 2 or more distinct identities or subpersonalities, also called alters. They recurrently take control of the patient's consciousness and behavior. Each identity may exhibit unique behavior patterns, memories, and social relationships. In many cases, the primary personality is religious with a strong moral sense, whereas the subpersonalities are radically different. They may behave aggressively and lack sexual inhibitions. They may have a different gender, sexual orientation, religion, or race than the primary personality, and may even differ in hand dominance, vocal qualities, intelligence level, and EEG readings. The primary personality may be unaware of the subpersonalities and may wonder about lost time and unexplained events. Subpersonalities are more likely to be aware of the existence of the other personalities and may even interact with one another. The transition from one personality to another is triggered by a stress or meaningful social or environmental cue. Although usually sudden, occurring within seconds or minutes, the transition can take hours or up to days. The switch from one personality to another is often accompanied by a trance-like state, change in posture, and rolling or blinking of the eyes. In order for one of the dissociative disorders to be diagnosed, medical and neurological illnesses, substance use, and other coexisting psychiatric disorders must be ruled out or identified as coexisting with the dissociative disorder. Medical personnel collect objective data from physical examination, EEGs, imaging studies, projective tests, structured personality tests, and specific questionnaires designed to identify dissociative symptoms. Assessing patients' ability to identify themselves requires more than asking patients to state their names. Changes in patient behavior, voice, and dress might signal the presence of an alternate personality. Referring to self by another name or in the third person and using the word we instead of I are indications that the patient may have assumed a new identity. The nurse should consider the following when assessing memory. Can the patient remember recent and past events? Is the patient's memory clear and complete, or is it partial and fuzzy? Is the patient aware of gaps in memory, such as a lack of memory for events, maybe a graduation or a wedding? Do the patient's memories place the self with a family, in school, or in an occupation? Patients with amnesia and fugue may be disoriented with regard to time and place as well as person. Relevant assessment questions include: do you ever lose time or have blackouts? Do you find yourself in places with no idea how you got there? Those situations are somewhat like if you have a person who drinks a lot and then the next day wakes up without any kind of regard to what had happened. And the nurse must gather information about events in the person's life. Has the patient sustained a recent injury, such as a concussion? Does the patient have a history of epilepsy, especially temporal lobe epilepsy? Does the patient have a history of early trauma, such as physical, mental, or sexual abuse? If DID is suspected, pertinent questions may include: have you ever found yourself wearing clothes that you cannot remember buying? Have you ever had strange people greet you and talk to you as if you were old friends? Does your ability to engage in things such as athletics, artistic activities, or mechanical tasks seem to change? And lastly, do you have different sets of memories from childhood? Is the individual depressed, anxious, or unconcerned? Many patients with DID seek help when the primary personality is depressed. The person also observes for mood shifts. The subpersonalities of DID assume control. Their predominant moods may be different than that of the principal personality. If the subpersonalities shift frequently, marked mood swings may be noted. Specific questions should be asked to identify drug or alcohol use. Dissociative episodes may be associated with recent use of alcohol or other substances, such as cocaine, opioids, sedatives, or stimulants. Has the patient's ability to function been impaired? Have disruptions in family functioning occurred? Is there possible secondary gain evident for this patient? In fugue states, individuals often function adequately in their new identities by choosing simple, undemanding occupations and have few intimate social interactions. The families of patients in fugue states report being highly distressed over the patient's disappearance. Patients with amnesia may be more dysfunctional. Their perplexity often renders them unable to work, and their memory loss impairs normal family relationships. Families often direct considerable attention toward the patient, but may exhibit concern over having to assume roles that were once assigned to the patient. Patients with DID often have both family and work problems. Families find it difficult to accept the seemingly erratic behaviors of the patient. Employers dislike the lost time that may occur when subpersonalities are in control. Patients with depersonalization disorder are often fearful that others may perceive their appearance as distorted and may avoid being seen in public. If they exhibit high anxiety, the family is likely to find it difficult to keep relationships stable. When a patient's life has been substantially disrupted, he or she may have thoughts of suicide. According to the DSM, over 70% of patients with dissociative identity disorder have attempted suicide, and self-mutilation, also self-injurious behaviors, are common. The nurse gathering data should be alert for expressions of hopelessness, helplessness, or worthlessness, and for verbalization or other behavior of a subpersonality that indicates the intent to engage in self-destructive or self-mutilating behaviors. Psychotherapy has been proven to be the primary and most effective treatment modality in dissociative identity disorder patients. The goal of therapy is to integrate all of the patient's personalities and to help with understanding that the different presenting affects can be expressed within one personality. Such techniques include psychoeducation, talking through traumatic reenactment, safety planning, journaling, and artwork are also helpful. There are no specific medications for dissociative disorders, but appropriate antidepressants or anxiolytic medications are given for comorbid conditions. Some therapists use hypnosis to treat patients with DID, although there is some controversy over this method. Therapists become overconfident in the accuracy of the information provided. This method seems to have informed consent due to the risks involved, especially when dealing with family members. The patient must also be made aware that any information given during the trance may be used for or against them if legal action is needed due to the content that they stated.